How's it going, guys? We have a difficult question for pathology. 19-year-old woman. Laboratory studies show normal calcium at 9 should be 8.4 to 10.2. Phosphate, normal 3.3 should be 3 to 4.5. The image is showing us the left foot, which is the right side of the image, has brachydactyly, so shortened, fourth, fifth metatarsals. Now, when you have the combo of fourth, fifth, brachydactyly plus short stature plus moon facies plus subcutaneous ossifications. This is known as the Albright hereditary osteodystrophy phenotype, AHO phenotype. And we're going to see this in two conditions, which are going to be pseudohypoparathyroidism and pseudohypoparathyroidism, D and E here. Now, choices B and C, pseudo-hyper and pseudo-hyper, don't exist, okay, in terms of being actual real diagnoses. For instance, you can have malignancy where you get high calcium and PTH can be suppressed. You can have the appearance of high PTH even though you don't. So they can be thrown around somewhat colloquially, but they don't exist for USMLE. So I threw them in here to be a malignant asshole, no pun intended, all right? So we're looking at D and E here. Now, the next step is saying, are our electrolytes normal or abnormal? They're normal. So our answer is going to be choice E. Now let me explain, okay? Just relax, very confusing here. When you have the AHO phenotype, as we said, brachydactyly fourth and fifth, can be anywhere, either foot, either hand, can be all of them, doesn't matter. When you have AHO phenotype and you have low calcium, high phosphate, high PTH, that's pseudohypoparathyroidism, choice D. We said the answer is E here, but I'm telling you that if you have hypoparathyroidism, wouldn't you expect your calcium to be low and your phosphate to be high? So when you see those labs in somebody, you say, oh, that's hypoparathyroidism. But you have high PTH, not low PTH. So it looked like hypoparathyroidism, but it wasn't, hence pseudohypoparathyroidism. Now, some of you who are very astute might say, but wait a second, when you have low calcium, high phosphate, high PTH, isn't that secondary hyperparathyroidism? The answer is you see that same profile in secondary hyperparathyroidism, low calcium, high phosphate, high PTH, but the vignette's completely different. You're going to have a patient who has renal failure. Okay, it's a long seminar, but when the kidney can't do its job properly and you can't reabsorb calcium, you can't activate vitamin D to get small bowel absorption of calcium, and calcium's low and PTH goes up to compensate, that's secondary hyperparathyroidism. But in the situation of pseudohypoparathyroidism, where you have low calcium, high phosphate, high PTH, you have the Albright hereditary osteodystrophy phenotype. It's not renal failure. So the vignettes are completely different despite the same profile of down arrow calcium, up arrow phosphate, up arrow PTH. So if you have a patient, whether pediatric case, adult case, and they have the Albright hereditary osteodystrophy phenotype, and you say, oh, this might be pseudohypoparathyroidism. But then you check their labs and you see, oh shit, actually, calcium, phosphate, PTH are all normal. That's pseudohypoparathyroidism. Our correct answer here, choice C, because we thought it was pseudohypoparathyroidism, but it wasn't. Okay, so you from a clinical standpoint, you essentially start off by the clinician is going to note the Albright hereditary osteodystrophy phenotype. Okay, and then your first inclination is it's going to be pseudo. You check the labs, it's not. You say, holy shit, it's pseudo, even more rare. Got it? So another point is that you have insensitivity to PTH with pseudohypoparathyroidism, where the G-alpha SG protein can't do its job the way it's supposed to. So this is a mutation in the GNAS gene, the maternal allele. It's an imprinting effect, results in insensitivity to PTH. And normally, PTH will cause urinary CAMP to go up because PTH acts through a G-alpha SG protein. So it causes urinary CAMP to go up. In the case of pseudohypoparathyroidism, parathyroidism, where you have resistance to PTH, urinary CAMP will be low, and there will not be an increase in urinary CAMP in response to exogenous PTH. Now, in pseudo, you also have a mutation, the GNAS gene, but it's on the paternal allele in terms of imprinting. And although we also get the Albright phenotype, we don't have the insensitivity to PTH. Okay, so your urinary CAMP is going to be normal. You will respond to exogenous PTH where urinary CAMP will go up. And as we said, your calcium phosphate, PTH are all normal in pseudo, whereas in regular pseudo, we have down arrow calcium, up arrow phosphate, up arrow PTH. Now, finally, choice A, McCune-Albright syndrome, threw it in there because it sounds similar, right? But it's completely unrelated. This is actually an activating mutation in GNAS that's a post-fertilization mitotic error. Okay, it's somatic. So you have increased G-alpha S activity, increased CAMP signaling. But this is going to be a triad of number one, coast of Maine cafe au lait spots is what they're called. So hyperpigmentation. In neurofibromatosis type 1, you get hyperpigmented macules. But in McCune-Albright syndrome, you get large, irregular, almost patch-like cafe au lait spots. So that's our first component of the triad. The second is something fancy called polyostotic fibrous dysplasia, which just means fractures. Okay, you get bone replaced with fibroosseous tissue. And then the third component is endocrine hypersecretion, usually precocious puberty. So McCune-Albright syndrome is that triad. It's activating mutation, post-fertilization mitotic error, whereas pseudo and pseudo are inactivating mutations in the maternal versus paternal alleles, respectively. McCune-Albright syndrome? Wrong fucking answer.